Dr. Jabr, it's a pleasure to have you here at our studios and in South Africa. I believe it's your second visit to South Africa. But before we go into that, I'd just like to find out from you more about yourself and if you can share with us your experience and your background.
I'm from Jerusalem, a Jerusalemite Palestinian, and I studied medicine in Jerusalem, and then specialized in psychiatry in France, and also at a later stage I studied different kinds of psychotherapy in the UK, and even at the Israeli Institute of Psychoanalytic Psychotherapy. And I practice as a psychiatrist and a psychotherapist in Palestine, and currently I'm the head of the mental health unit that supervises all mental health activities in the West Bank.
Okay, you've written extensively about the consequences of Israeli occupation in Palestine. Can you share with us more about your findings and the effects that it's having?
Well, usually people, when they ask about findings, they want research results. And I have to say that our research in Palestine is not comprehensive. We don't have comprehensive epidemiological studies that give us a prevalence, an accurate prevalence about mental health problems in Palestine. But we have several researches and studies that were done in different contexts, because the Palestinian population is so fragmented and the political context is different in different geographical areas. For example, we cannot assume that the situation for Jerusalemites is the same like the situation for people from the West Bank, and it's quite different in Gaza. So we cannot make generalizations about all Palestinians. A new study that was published by the World Health Organization in The Lancet only a week ago arrives to the result that 22% of the population in a conflict area is expected to have psychological complaints, even mental health disorders, like common mental health disorders. And the most common disorders that we encounter in the clinical practice are like depression, anxiety, somatoform disorders, and trauma-related disorders. Usually in Western literature, they describe that as post-traumatic stress disorder, but in our practice we observe something different than the usual description of PTSD, a terminology that has developed from the experience of Western soldiers who move from one area to another, to the war zone, and then they go back to the safety of their home. While for Palestinians, trauma is ongoing, it's not finishing, and the threat is not imaginary, it's there. And there is no safe place after a traumatic event, so which makes the terminology different for us, and also the means of intervention different.
And how are they coping at the moment in Palestine from the patients that you've been seeing?
In Palestine, we have the challenge that mental health professionals are very few. For example, there are 2 million people living in Gaza. They have 10 psychiatrists. In the West Bank, we are 22 psychiatrists for 3 million people. We have a small number of clinical psychologists and psychotherapists. Nevertheless, we are trying to do the art of the possible. So we train many people who are not mental health professionals to provide low-intensity interventions. For example, we have trained medical doctors, general medical doctors, and nurses to provide psychosocial support and mental health interventions for the population that they meet in primary health care. We have trained many teachers and school counselors, a huge number of personnel who work with children in school setting, because in Palestine, Palestinians are a very young population. 1/3 of the Palestinians are at schools. So if we provide the service in school setting, that will be suitable for the small number of highly specialized people that we have. And it is also an intervention that circumvents pathologization and medicalization and stigmatization of individuals who are affected. Because I think, like I just mentioned the research that was done by WHO, I think there is a lot of suffering and psychological pain. We cannot assume that anyone who has psychological pain or psychosocial suffering is sick. So we try to make our interventions less medicalized and less pathologizing.
And how do you do that?
It's by providing and equipping many people who are not highly specialized mental health professionals with the necessary tools to intervene when people suffer. For example, after the home demolition, the demolition of one Palestinian family's home, we don't send a psychiatrist to do the intervention. People who are volunteers usually go and provide low-intensity intervention, telling people that after a big incident like that, they might suffer from psychological symptoms, psychological pain, and that is normal. But if there will be more symptoms over a longer period of time, they know the addresses where they have to go. We try to provide the minimum support that people need in these difficult circumstances, basic needs, a shelter for people who lose their homes, for example. And I have to say that in spite of the difficult situation in Palestine, there are also some protective factors for the Palestinian people. This is a population that's highly educated, a population that gives a big value for the family structure, and there is a social cohesion and genuine solidarity within the people, to the point that in spite of all the poverty in Palestine, all of the home demolition, you don't find that people sleep in the streets in Palestine. You don't find people eating from garbage in Palestine. These observations I saw in the West more than I saw in Palestine.